It's a real privilege to be here. This is very much going to be a whistle-stop tour. We have half an hour to talk about an absolutely huge topic, so we're clearly not going to cover everything at all. And as Tamsin said, we will be touching on some really very sensitive issues to do with self-harm and suicide. Please look after yourselves. Take a moment away from the screen. Talk to someone if you're feeling distressed about any of the content that you hear today. Leave the webinar. Do what you need to do to stay safe. But they are important topics. And I think too many times we perhaps shy away, particularly as professionals, from discussing these issues. Because it is such a huge topic, I'm going to focus on one of the most common mental illnesses, that's depression. But also I want to talk briefly about psychosis, which is a rarer mental disorder following a brain injury, but has a massive impact. And so they're going to be the two issues that we're going to focus on today, looking why those issues might occur, briefly discussing treatment, but also thinking about barriers to accessing healthcare support, and your suggestions for how things might be improved as well, because I'm here very much to listen as well as to talk today. I've got a bit of a dodgy accent, as you can tell. Sometimes I speak too quick, so please forgive me for that. Unfortunately, I've had it for over 50 odd years, so it's unlikely to get any better. So I'm teaching my granny to suck eggs here by telling you how common brain injury is, and you know that extremely common. About 1.5 million people every year suffer from a traumatic brain injury, and about 20,000 that's a moderate or severe traumatic brain injury with life-altering long-term consequences. What we also know, but hear less about, is that the psychological impact of brain injury is much more common and has more impact often than the physical impact following a brain injury. And that all mental disorders, all mental illnesses are more common following a brain injury. So that's anxiety, post-traumatic stress injury, stress disorder, psychosis, sleep disorders, depression, substance use, you name it, it is more common following a brain injury. The brain injury does not cure mental illness. So why do we not hear more about mental illness and brain injury? Well, it's because really traditionally rehabilitation has been focused on improving independent living skills following a head injury. So, and very rightly so, focusing on mobility, on speech, on being able to feed ourselves, those survival independent living skills. But of course, we know the brain does more than that, doesn't it? And so often the cognitive, emotional and behavioural impact was sidelined or neglected or given less priority. And whenever something's given less priority, that doesn't just mean sort of the thinking about priorities, it means the resources as well. Thankfully, over the past decade or so, things have significantly improved in terms of a more holistic approach to neurorehabilitation, but we still have a long way to go. And as we'll see and hear today, and I'm sure I'll hear from your stories as well, those barriers and that lack of focus and lack of resource still can exist. So let's talk a bit about depression. So depression is one of the more common mental illnesses. It affects about 15% of people in the developing world, and there's some peaks in 20s and 30s and again in the 50s and 60s. And there's a very clear definition of depression. It's characterized by an absence of a positive affect, and that means a loss of interest and enjoyment in ordinary things and experiences, having a low mood, and also a range of emotional, cognitive, physical and behavioural symptoms. And to have a formal diagnosis of depression, that has to be present almost all of the time, every day for at least 2 weeks. So it's a really quite distinct diagnosis. It can be classified as mild, moderate, severe, can be atypical, and it can obviously also be associated with suicidal thinking and intention. It's different from dysthymia. So dysthymia is a chronic low mood, so less severe symptoms, but for lasting longer, often months or years, someone can have chronic low mood. And adjustment reactions as well. And an adjustment reaction is a change in your mood following a change in your circumstances. And we saw this in the Barbie movie for a little bit of lightness. So Barbie, she lost interest in herself and her self-care. She became low in mood. She became very tearful as a result of the introduction of the patriarchy. And she was immediately cured whenever the matriarchy was reestablished. If only life was that simple. So these are kind of examples of not just the psychological effects of depression, but also the physical and the social impacts. And often the physical and the social are neglected whenever we're thinking about depression. We just think about low mood. But things like, effect on pain, on appetite, even our bowels can be affected by depression, our sex drives, menstrual cycles, and then the avoidance and withdrawal from social interactions as well, and the outcomes that has. So depression is a common mental illness, as we've seen, but after a brain injury, just have a look at those statistics, even more common. So 10 weeks following a brain injury, 56% of people could be diagnosed with having depression. And in the first year following a brain injury, 57% could be diagnosed with a depressive disorder following a moderate to severe traumatic brain injury. And whenever you think back to those symptoms that you get with a diagnosis of depression, just think about how major an impact that will have on someone's recovery journey if they're suffering from those symptoms. And we also know that depression can present atypically or with symptom masking following a traumatic brain injury. And some of the ways it can present that might be unusual is maybe an increase in irritability, of not getting along with others, sometimes to the point of being really agitated as well. It can present with avoidance behaviours, so not attending appointments, keeping yourself locked away or isolated, not wanting to go out. It can look like fatigue, and we know that fatigue is hugely common after a traumatic brain injury, particularly in the early days, and that can often be misdiagnosed, for depression. And health anxieties as well. So someone becoming increasingly anxious about their health. And that could be seen as sort of normal behavior following such a traumatic event, with maybe frequent attendances at the GP and that person being labelled as maybe difficult whenever it actually is their mood and resulting anxiety and depression. And we also can see sometimes that one of the indications that somebody after brain injury might be suffering from depression is that their cognitive function isn't as good as would be anticipated by the type and nature of brain injury that person had. So, for example, maybe somebody is presenting with more memory difficulties than really they should have for the sort of brain injury that they have suffered. And that may well be an indication that person has depression. And then all the therapies in the world that are thrown at that person for cognitive rehabilitation may not be successful if the depression isn't treated or asked about. So I know that whenever we were setting up this webinar, a patient of mine, and I will call him a patient because I've given him treatment, wanted to come along and speak to us today, but unfortunately he's unwell, but he's allowed me to share his story, but not to share his name. So we're calling him Sam for today. And he has, as I say, allowed me to tell his story. So Sam had a traumatic brain injury whenever he was 11 as a result of a road traffic accident. He spent a year in and out of hospital, recovering, missing lots of school. He eventually returned to school and he really struggled. He fell behind in his class, he was bullied, he started to skip school, and he hooked up instead with a local gang who gave him drugs, but they also gave him a peer group. He felt that he belonged. He started to self-harm at the age of 14 by cutting, and he took more drugs and started to commit minor offences, stealing and things like that. And his self-harm really escalated with overdoses, ligaturing, and repeated cutting. He was repeatedly arrested by the police for doing things like threatening to throw himself off bridges, run in front of traffic. He had multiple assessments by crisis mental health teams, and he was diagnosed with a personality disorder at the age of 19. He was offered 6 psychology sessions. That seems to be the standard. He missed the appointments because he lost the letters, and he was then labelled as not engaging. Not once in his records during this time is his brain injury mentioned. Not a single time. This cycle continued until the age of 25, and he committed a serious offence, and he got a prison sentence this time. He struggled in prison, and he was referred to the prison psychiatrist, who took a history and listened to him. Listened to him. That's the key. He was transferred from prison to hospital, had a neuropsychological assessment, and offered treatment that was adjusted to his cognitive needs. He stopped self-harming completely. And although he still has ups and downs with his emotions, he now has an armory of coping strategies that he can take into the rest of his adult life. And whenever I think of Sam's story, and whenever I've talked to him about it, the biggest regret of all is that he wasn't listened to sooner, and that he didn't have those interventions for his mental health sooner. And he wrote a poem, and he wanted me to read it out today. And this poem is hanging up in our trust headquarters because he did some artwork along with it as well. So it's called "Recovery is a Journey to Discovery." I've seen brain injury in reality. It's like battling with the devil of insanity. Depression, self-harm, and several personalities. Low self-esteem. It's a tragedy. Bad days led to sad days led to self-harm. People come, people go. Don't do drugs. It's not the way to cope. Always be kind and stay positive. Confidence is key to progression. My journey has just begun. Hospital has given me the ammunition to complete my mission, to be in the arms of my family again. So I think Sam's case really highlights so many of the barriers that there are for people accessing appropriate mental health care following a brain injury. One study we looked at, 60% of people had not been asked at all about their mental health in that first year following a traumatic brain injury. There's often a lack of specialist services and training for healthcare professionals, and that's through the whole stage of primary care, talking therapies, and secondary care. Many people with a brain injury face exclusion criteria. We don't see people with a brain injury. We don't see organic causes of mental illness. And then, as in Sam's case, being discharged from services due to not attending. And of course, we know that that can be for multiple reasons, because the health service does not make it easy to get appointments and to access appointment systems. But also people with a head injury, and again, I'm talking to the converted here, can face bias and discrimination with negative attitudes as well. And something that I've come across time and time again is this feeling of, I should be feeling glad to be alive. I hear from people who have tremendous guilt because they feel that they should be focused on rehab, trying to please their family and their friends, being strong, whatever that means. But inside, they just feel really, really sad and really down. And because of the shame and guilt that they feel, they then struggle to tell their family about that because they feel it will be letting them down. And that also then can create a barrier for that person accessing help. I've heard from people not wanting to disappoint physiotherapists, but they just really can't get out of bed to go to attend physio. And so they just slide away from that, and that impacts then physical recovery too. And now just to mention about suicide, because as I said earlier on, this isn't just about feeling a bit down, a bit low in mood. This is a physical, a psychological, a social series of symptoms that can have very serious consequences. And one of the most serious of all is someone who is at the point where they feel they can't live anymore. And there have been large population studies that have confirmed that if you have a brain injury, you are at 2 to 3 times more likely to complete suicide than if you don't. And they're really shocking statistics. Other studies have shown that about a quarter of people with a brain injury have thought about suicide, even fleetingly, in the first year. And that's even higher for adolescents, a particularly vulnerable and at-risk group. And unlike some other health conditions, the risk is lifelong. So for example, if you're given a cancer diagnosis, your risk of suicide is highest in the first few weeks and months after that diagnosis. But with a brain injury, it's a lifelong risk. And we know that there are some associations. So some people who are maybe more likely to have suicidal thoughts or contemplate suicide. And that's really if someone has very early mood symptoms following a brain injury, if they have a past history of mental illness, and maybe past suicide attempts also. We also know that the more severe the brain injury, the higher the risk. But also we're finding out more, aren't we, about the impact of repeated mild or moderate traumatic brain injuries and how that can lead to mood and personality changes. And we're thinking in particularly vulnerable groups, so people who've experienced repeated, multiple intimate partner violence, domestic violence, children who've suffered physical, emotional neglect, abuse and trauma, contact sports. And obviously, it hits the headlines, doesn't it? About, sort of elite sports people who've had repeated trauma and the effect that it has on their mood. And we have seen suicides as well in elite sportsmen with contact sports, violent assaults, and also massive area that we could spend days talking about is brain damage due to substance and alcohol misuse as well. So why? Well, it's complicated, and it should be complicated because the brain's a complicated thing and we're complicated people. So whenever we talk about what's causing depression following brain injury, it's not just about a brain that was where it was and what type of damage may have occurred at a particular point in time. It's about your previous mental health, your previous brain health, your previous experiences, as well as the nature and location of the injury and how that may disrupt pathways involved in regulating mood, as well as the impact of the brain injury on, for example, pain, daily functioning, your thinking, and your social circumstances. That can all contribute to causing a depressive illness following a brain injury. And there's a body of evidence, a body of research going on at the moment looking at predicting depression, depending on the nature and location of brain injury. And the aim of that will be to identify people who are maybe more at risk and starting treatment prophylactically, so starting it early to prevent a depressive illness. And in so doing, helping with recovery and rehabilitation, making it more successful. And one of the theories is around the impact of inflammation on the brain and pituitary stalk damage, and that's particularly following base of skull fractures, shearing and blast injuries as well. So the research needs to ramp up, doesn't it, with such a serious condition. And thankfully, there has been a bit more interest from the Research Council about funding these projects. So I'm just going to move on briefly to talk about psychosis. So psychosis is a collection of symptoms that alter a person's perception of reality. So that can include delusional beliefs, thought interference, and hallucinations. It's relatively rare following a brain injury, about 1%, which are quite low numbers, but it can go up to 10%, and the risk increases over time. And there can be a latent effect. So, you can develop a psychotic illness following a brain injury up to 10, 20 years following it. And we know that there is an association with epilepsy as well. If you develop a psychotic illness following a brain injury, this is called an organic delusional disorder. And these are the types of symptoms that you can have with organic delusional disorder. And they're all pretty serious. So having persecutory delusions, hallucinations, misidentifying people, and that's particularly problematic when it comes to carers and can lead to perhaps carers being assaulted, etc., by someone who may have this disorder. And also there'll be cognitive impairment as well. We see quite frequently, and about 30% of people will have epilepsy, in particular temporal lobe epilepsy. We know also that if someone has a history of a severe mental illness like schizophrenia, they are more likely to actually go on and have a brain injury. And we could talk about that for a while, and that may pop up in the questions as well. And there is this association between early onset psychosis and having had a brain injury in younger life as well. And this is really important because this can impact treatment. So it may help us to understand why maybe someone with schizophrenia isn't responding to traditional or conventional treatments is because no one has taken account or asked about a brain injury and made the necessary adaptations. And so they're not going to get better unless those adaptations are made in treatment and treatment responses. So another patient story I wanted to tell you, and this is M. So M had a cerebral abscess. He had an ear infection that then spread into his temporal lobe. And he was 20 when he had this. He had surgery in his temporal lobe, following which he developed epilepsy, memory difficulties, and he had some behavior changes. He had hallucinations and paranoid delusions too. His English was not his first language, and that led to all sorts of barriers in him accessing care. He also led a vagrant lifestyle. He had his epilepsy treated, however, partially treated because he didn't like taking the medication, so would often skip doses. But his psychosis wasn't treated because no one asked him any questions about his mental health. He started to use drugs to try to make the voices go away, and this made him even more paranoid, and he committed a very serious offence. So M had no insight at all into the risks of his behaviour, and he required the Mental Health Act in order for him to come into our hospital and receive treatment for his psychosis, his epilepsy, and help with his memory problems. At the minute, and I saw him yesterday, he's doing a tiling course. He also really enjoys making objects out of wood. He's never had a job in his life before, and he's looking forward to getting some employment. And he is symptom-free. He doesn't have any symptoms of psychosis, and his epilepsy is under control. And he's currently learning new independent living skills. So what are we going to do now? There might be some people in the audience who remember Spike Milligan and his sketch show, and this is my dad's favourite thing. What are we going to do now? Whenever I came to him with a problem, he always said, what are we going to do now? So I think if you take away anything at all from today's talk, and hopefully something, is ask. Please ask about mental health. If you don't ask, you don't know. And if you have suffered from a traumatic brain injury, then please tell and talk about your mental health. 56%, that's not a rare thing, that's a common thing. And it is a symptom of brain injury in my account anyway. And so talking about this shouldn't be stigmatized. It should be a normal part of the inquiry into someone's health following a brain injury. And often people will ask me as a psychiatrist, well, if I ask about suicidal thoughts, will that make the person then think about suicide? Am I increasing the risk? Well, there's been a large study done, and actually just day to day, by working for nearly 30 years as a psychiatrist, that actually acknowledging and talking about suicide may in fact reduce the likelihood of completed suicide, and can actually lead to improvements in mental health. So don't be afraid to ask those serious questions. And ask the carer too. Always get another person's view on things. Obviously, getting consent to do that, important. But finding out from the carer, what have they noticed? Have there been subtle changes? Something that's concerning them that needs more exploration. There's also, as I said, that really therapeutic impact of having the conversation, that sense of relief that you can get from, I'm in a safe space now where I can actually talk and tell people how it really is. There are screening tools that can be used for professionals. I've listed them there. And always do a risk assessment if you're a professional or a carer as well, and have a crisis plan. So what if things aren't getting better? What do we do next? Informing and educate. So name it. I don't know about you, but don't we all feel better whenever we know what's going on with us? You know, whenever we can get a diagnosis for something. And that again can give that sense of relief. I'm not going crazy, I'm not mad. This is a symptom. of what has happened to my brain at this point of time in my life. Giving information and signposting to a said client, patient, person who's had a brain injury and their carers about mental illness. Headway have some fantastic resources, Brainkind the same, and Collaborate as well. If you're a healthcare professional, no point, just giving somebody information and leaving them with it. Talk to them through it, make sure there's understanding about it, and coming up with plans together. And then understanding. As we said earlier on, this is a complex issue. And so if you just treat the biological without looking at the psychological and social, well, you're never going to get the functional outcomes that you're anticipating or that you're hoping for. So if someone has maybe psychological therapies to help with emotional coping strategies, but they're still living with daily pain from headache. We know chronic headache is a terrible issue, or they can't afford to pay their rent or to put food on the table. And so their brain isn't receiving the nutrition that they need in order to be helping with the rehabilitation. Well, then you're never going to get an optimal result from treating, despite good intentions and best intentions. Treatment is the same. Oh, my computer's going to restart. Just give me a moment. Sorry. That would not have been a good thing. Maybe it would. Treatment is the same. So as a psychiatrist, I'm constantly saying to our trainees, there's no magical thing that you need to do for treating depression. You know how to treat depression, whether that's in somebody who is a brain injury or not, or a neurological condition or not. But you do have to be aware that it has to be adapted. Treatment has to be adapted. So for the psychological therapies, adapting those, individual rather than group therapies are better. And also bringing in some of the cognitive rehabilitation strategies. As I said earlier on, if somebody has some memory difficulties, then just making sure that you're not saying to that person, here's your homework to do for next week, that you're ensuring the person understands what the strategies are, and is given some resources around supporting that. Meaningful activity. I cannot emphasize that enough, how important it is to have a reason to get up in the morning, something to look forward to, something that you will get some pleasure from as well. Super, super important. And that includes physical activity as well as mind activity, and creative arts. Medication, I'm a doctor, so of course I'm going to talk about medication, but it does need adapted because we need to be aware of seizure thresholds and of the increased likelihood of having side effects from medication. The other thing I wanted to emphasize was, what is the goal? So working collaboratively to think about what the desired outcomes are from an intervention, because sometimes, depending on the type of brain injury, that may not be an emotional outcome. So although most of us would like to, well, I'd like to feel happy, it might be that that person just has some uncoupling of their emotions. And so it will be a functional outcome rather than an emotional outcome. So that person may be better able to get on with their day, to prepare a meal for themselves, to go to employment, but that feeling of happiness may still be slow to come. So just being aware of what the goals are. Carer support, again, can't emphasize it enough, a crisis plan. And then if you're coming across barriers, just looking at the watch, we're nearly bang on, let us know. So let Headway know if you're coming across barriers to accessing mental health care. Let UKBIF know, UKBIF know, and the Neurological Alliance. There are fantastic advocacy services out there who want to hear your feedback about those barriers, and they feed back to us at the Royal College of Psychiatrists as well. We know that there is a long way to go to integrate mental health with physical health care, with strategies around it. Like everyone else, we're facing resource issues, but the more information we have about these barriers, the better armed we can go to lobby parliamentarians who are the ones who hold the purse strings. I'm not going to talk about medication too much. I've said it already. So some resources that are available, say Headway resources are amazing. Mind, NHS 111, Rethink, Samaritans, The details are there, and they're available on the Headway website as well. I love Dolly. She's my guru. And this is my favorite quote, and people who've heard me speak before have heard me quote this so many times. And she has classic one for quotes. But we can't direct the wind, but we can adjust the sails. So you've had a head injury, you know, that's been a life-altering event that you've had. What can we do to change the direction of that recovery, to steer and to help to steer things in a more positive direction? Thank you very much for listening.